And I would like to start by thanking the organizers of this wonderful meeting for allowing me to make a point on the orthopedic implants. Orthopedic surgery relies on some concepts of implantation that will be displayed during this talk, because many of the solutions require probably a sharper view than what has been the traditional industrial approach. I would like to go on with my view on the implantation problems that we face in orthopedic surgery. And I will address some of the issues related to bone and joint reconstruction in terms of orthopedic substitutes for bone filling, defect and reconstruction, as well as implant fixation issues. Thank you, and thank you all for your patience. Now we are delivering the presentation, as I mentioned before, in the following outline. We will focus on orthopedic implant requirements, and I will mostly address bone repair and regeneration problems and bone implant fixation problems, as well as the prevention of infection. We will then study how to manage bone defects, how to improve bone implant fixation, how to avoid implant infection, and I will make some suggestions about possible future directions and opportunities. So, the orthopedic implant requirements are considerable. If we look at three main aspects that we require for bone repair, and these are musculoskeletal trauma, which is a tremendous amount of bone defect production, as well as osteoporosis-related fractures, and this in the first world is a growing problem affecting significant parts of the elderly population, as well as spine surgery, most of it directed today to bone fusion, for what structural support and bone healing enhancement is required. These are some examples of what we saw before, and this is a huge bone defect that was corrected by fixation, but also leaving some areas here that require bone structural support. And this is a case of subtalar arthrodesis, where in spite of fixation, in the CT scan we can see that there has been no bone healing, with lack of interpenetration there, requiring other approaches. This is also the osteoporotic trauma related patient, and we mentioned before, this is a well-corrected hip fracture where a bone gap there produces the collapse of the whole construct. And if we look at the figures, the lifetime risk at age 50 attains almost half of the population, particularly in women, and this is a matter of real concern about how we can produce substantial reconstruction there. And here is one of the percutaneous approaches where distal radius fracture has been filled with a bone filler cement by an injection there, so as to reconstruct that bone, but this still has significant problems. In the other side, bone implant fixation accounts for growing figures of total knee and total hip implants, and these are American data, and you can see that the projected numbers are steadily increasing, and probably in some years figures will be 6 times larger, which is distressing. And if we look at the reoperation rate and the revision required with more problems in fixation and reconstruction, this is still growing and growing. if we look at European data, we recently published a combined international study, and the same trends are observed in most of our countries, which is the reason why we are becoming more and more concerned about fixation and failure problems. And trends are quite different from country to country, and if we look at a classical register view, which is the Swedish register, we can see that in the knee, most of the implantation is requiring cement. This is about the same all over the world, and this is the Canadian registry showing also significant numbers of cemented implants, whereas in the hip, and this is also from the Swedish hip registry, most of the solutions are also cemented in the Swedish registry, whereas in the Canadian registry most of them are cementless, and there is some significant divergences from country to country, accounting for problems in reconstruction. Here are some views in surgery of a cement, of a defect in an acetabulum, where you see holes generated by previous screws and other defects, which requires new approaches, trying to stabilize, filling these defects and stabilizing with new materials and surfaces in the implants. Or else, in these significant defects here in the acetabulum and in the femur, other solutions requiring large amounts of bone and other techniques are needed, which is a problem to generate enough bone or to provide enough bone support there. Here's a different problem, and this is a hip that went reconstructive surgery, and within 1 year there has been a failure in the upper side of the acetabulum, and the case was of infection. When all the prosthesis was removed, different spaces were required, but the amount of bone that was lost at that occasion was huge, which prevents further reconstructions or increases complexity. So infection is a tremendous problem, not only in the hip but also in the knee. And if we see these failure rates from the Swedish register also, loosening in the long term, loss of fixation and infection account for half of the problems related to knees. And here are some knees where loosening is appreciated in the upper part of the femur or in the tibia. Here and here you see a lack of bone surrounding the implant, and this is a case of infection where large amount of bone has been lost around the implant, losing fixation. So real problems are there, and these are increasing in view of the increasing rates of implantation. And how we manage this? Well, in the first side, how we manage bone defects, basically enhancing or trying to enhance bone healing, and this requires different approaches from osteoconduction to osteoinduction and osteogenesis in view of the multifactorial issue of bone loss. You see here total knee replacement where substantial bone loss surrounding the implant needs filling that gap, or a large defect that also needs filling with, in this case, bone graft and allograft. Orthobiological and what has been called surgical therapies include all these three aspects: structural bone support, growth factors, and cell-based devices and drugs. And for these approaches, a new brand of products has been generated. Major areas covered, and I will focus mainly on synthetic bone grafts, which are needed to provide this support, produce substantial revenues, and this is based on the Spanish market, but this is quite parallel in many European countries. And we see that there is a growing requirement and market for these bone graft substitutes in comparison with other aspects in the orthobiological area. And many companies provide some solutions which are available or under development, so the field is competitive. However, most of them offer only partial solutions in the search of the best bone tissue engineering, and most of them based on biomechanics, but this still requires many aspects so as to regenerate new bone, partially due to the non-biodegradability, complete biodegradability of the supports, and also with interaction problems with cells. So bone defects still need better substitutes if we are facing larger requirements, and these different issues are being focused on this topic, particularly looking at seal adhesion and differentiation related to the material. And in our group we've been doing some experiments with nanohydroxyapatite and other aspects, and the field is really to be developed there. Because we know that roughness down to nanostructure affects cytoskeleton changes in the cell, and this affects proliferation and differentiation, which may be the clue for obtaining a new bone there. Also, the induction of bone based on the delivery of different proteins, and these are studies in our group based on PTHRP in a mesoporous material, but different ways of locating these proteins within the material are required, and substantial differences are appreciated between these two in an animal model where large amounts of bones are created by this osteoinductive way. If we look aside of bone regeneration, another very important aspect I already stressed is how to improve implant fixation. And this is a different surface osteoregeneration, but switch from cemented to uncemented implants may offer different possibilities. And this was tried before, and in the 80s, based on the micro structured patterns, some progresses were performed, but still to enhance bone ingrowth and fixation is a key aspect, because seal adhesion is variable. And osseointegration has been obtained in the mandibular bone, but other bones are not so easy to adequate an implant, because not only the adequate micropore is a tissue, but surface chemistry and nanopattern is there. And I already mentioned nanoapatite compounds in the surface of coatings, and this is relying on the interaction of cell and material, because basically it's not so difficult to get a primary block at implantation, but to maintain this adequate bone implant for a long-term fixation, which is not so evident. And this is also from the Swedish register, when we see that cemented implants perform well up to 30 years in 70% of cases, but non-cemented implants at 10 to 15 years have the similar rate of failure, which means that cement-less implants are still failing. In this context, it's not only a question of long-term fixation, which is one of our aims, but also to avoid implant infection, because this absolutely modifies the possibility of maintaining that fixation. And surface changes leading to infection-resistant implants is an overall interest of large parts of researchers and industrial partners, both in implant coating and antibiotic antiseptic delivery. and probably others are strategies well under development. Here are some studies of our own, both in biofilm formation avoidance and inducing bacterial death based on surface coating modification. This is a fluor nanotube coating of titanium, and other possibilities are to be discussed. So let me finish my presentation focusing on some future directions and opportunities. I would stress both in bone repair, in the diagnosis, the local delivery, and the local regulation of the combined factors required for bone repair, but also in regeneration and basically interacting with cells based on scaffolds with a particular attention of this relationship with cells, as well as local delivery or gene therapy to enhance this osteogenic potential in mesenchymal stem cells in the surrounding of the implant. Talking about permanent implants, joint reconstruction requires not only enhanced bone fixation in the early phases, but also a long-standing, long-lasting osseointegration, which requires different maintenance of the remodeling bone surrounding the implant, decreasing degradation also and wear at friction pairs to decrease also the inflammatory component of such a loss of fixation, as well as orthopedic infection issues that are also under discussion. And I would like to thank you for your attention, and I am ready to any questions. Thank you.